Hello everyone, it's a great honor to be with you today, presenting at IFNS 2022. My name is Jose Telich, and today I will be presenting the work Craniofacial Surgery Needs in the Moebius Syndrome Population, done at the Plastic and Reconstructive Surgery Division of the Hospital General Dr. Manuel G. Gonzalez in Mexico City. Our team has no financial disclosures. As background, we know that Moebius syndrome is a developmental neurological disorder that's characterized by the presence of unilateral or bilateral facial and abducens nerve paralysis. Patients typically present with congenital esotropia and a mask-like expressionless face. Patients with Moebius syndrome may also present palsy of other cranial nerves, as well as a wide range of associated cardiac, musculoskeletal, and craniofacial malformations. This set of malformations may include defects in the extremities, such as clubfoot or hand anomalies, Poland syndrome, and other craniofacial alterations, such as small mandible or even cleft palate. Therefore, this group of patients will need to be seen by a wide variety of specialists throughout their entire life and be submitted to a wide range of surgical procedures. So knowing what types of procedures is very important so a multidisciplinary team can be familiarized with them. Our team previously reported cephalometric analysis of these patients, and our results, as well as results from other centers, have found that patients may present with several common alterations, such as a flattened nasal bridge, micrognathia or retrognathia, mandibular hypoplasia, having a hypoplastic tongue, temporal mandibular joint ankylosis, high arch or cleft palate, external ear defects, as well as teeth problems such as having skeletal class 2 or even having incisors in proclination. And these patients may also require orthodontic care later in life. However, we aim to find out what kind of surgical craniofacial surgery procedures are needed by Moebius syndrome patients. We couldn't find more than one result when doing the search in PubMed, and this was just the report of 2 cases. When we broadened our search to other search engines, we found that there are no reports on this subject, and most articles that have been published either focus on case reports for a single procedure done on a single patient, such as an orthognathic surgery case or cleft palate correction, or even dental care for one single patient. Therefore, the objective of our work is to present our institution's experience in providing craniofacial surgery to patients that have a diagnosis of Moebius syndrome. As for our methods, we performed a retrospective and cross-sectional study, which we included every patient with Moebius syndrome that was seen at the peripheral nerve clinic of the Hospital General Dr. Manuel G. Gonzalez during an 8-year period from 2011 to 2020, and who also required any type of craniofacial procedure done either by the Craniofacial Surgery Clinic or the Cleft Palate Clinic. We did a data sheet and a database, and we included the main diagnosis, the type of malformation, as well as the type of surgical procedure performed on the patient. Statistical analysis was descriptive, and we included means as well as results are presented as percentages. For our results during the study period, we saw 153 patients at the peripheral nerve clinic with a diagnosis of Moebius syndrome. Out of those 153, 16 patients, equivalent to 10.4%, required some form of craniofacial surgery, either for bony tissue or soft tissue. From these patients, there were 11 females and 5 males. Patients had a mean age of 18.3 years, and in total, 19 procedures were performed during this study period. There were several different diagnoses in our patients, which was not unexpected. The main diagnoses were microgenia and cleft palate, followed by hemifacial microsomia. Other important diagnoses were microtia in prominent ears, epicanthal folds, microstoma, and ankylosing. For the surgical procedures, there was once again a wide variety of procedures, but the most commonly performed procedures were sliding genioplasty to take care of micrognathia, palatoplasty for cleft palate. We did 2 cases of epicanthal fold correction, 2 cases of facial lipofilling, as well as a mandibular distraction, 1 case of bilateral ear reconstruction with costal cartilage, 1 otoplasty, and some perioral surgery, including macrostoma correction, 2 cases of frenectomy, as well as an upper lip elongation doing the BY mucosal advancement. So as discussion, we see that management of the multiple clinical problems present in patients afflicted with Moebius syndrome requires intervention by a multidisciplinary team. As we mentioned previously, over 10% of our patients with Moebius syndrome required some sort of craniofacial surgery, either for soft or hard tissue. And this, once again, raises the alarm that multidisciplinary care is very, very important for these patients. For diagnosis, we found that microgenia and cleft palate were the most common diagnosis, but were not the only ones. When we compare our experience with results from other sites of the world, we did a previous report only considering basal diagnosis of clinical characteristics of Moebius syndrome. We have reports from Colombia as well as Italy where they reported information on craniofacial diagnosis. We see that cleft palate and microtia have fairly similar prevalence. However, retrognathia is higher in Colombia, as well as cleft palate seems to be less common in Italy. However, we have to take into account that these results may also refer differing referring practices around the world, and that this series that we present is the first time we do a series reporting surgical procedures performed on our patients. In our experience, even though on the first patient series we saw a higher prevalence of cleft palate, microtia, and micrognathia, we had fewer craniofacial surgery done at our hospital. This may represent several different referral practices done in Mexico, since there are several centers around the country that perform craniofacial surgery successfully. However, our center is practically the only one that focuses on surgery on Moebius syndrome patients. Therefore, patients are referred to us for facial reanimation, but may arrive later in life with us. However, this is still the largest series on craniofacial surgery performed on patients with Moebius syndrome around the world. As a conclusion, we would like to emphasize that 1 in every 10 patients with Moebius syndrome will need some sort of craniofacial procedure, and therefore management should be individualized and performed by an experienced multidisciplinary team in order to improve patient outcomes. Thank you very much. We're open to questions, and if you're willing to contact us as well. Thank you very much.